Thank you all. We've got plenty of time for questions and discussion. So, Lauren?
Many of the models for high-cost, high-needs patients are operating with minimal resources, and they're very highly iterative. I just wondered what your recommendation would be for best practice research evaluation of effectiveness.
Yes, and I would point out that they require enormous investment up front, most of these programs. That's one of, sorry, I would point out one of the real reasons. I did get it green, but it went off again. Is it working? It just keeps dying. Sorry.
If others have their lights on, you can turn them off.
Okay, yeah, now it seems to be, it's red, but it seems to be, is it working? Okay. Yeah, I would point out that one of the most important barriers for this is the lack of capital, because most of if a delivery system is doing this, it's very intensive. You have to staff with the social workers and the nurse coordinators and the mental health counselors and all long before you actually start to see the savings, well, at least 6 to 8 months before you start to see significant savings. So that's a big barrier. And you also would have to spend a lot of money under most circumstances if you were going to do a real controlled trial kind of thing that we're implying you ought to be doing. Most delivery systems are never going to do that. There is with PCORI and I think ARC, someone was here from ARC also, yeah, a real effort to get at rapid cycle evaluations and the methodology for that. I'm not an expert on it, but at UCLA we had a very good group at the VA and UCLA working on rapid cycle evaluation with both ARC and PCORI, and they helped us set up our design for what we were doing, and we were lucky enough to have around 10 clinics in our intervention arm, and we didn't have resources to get to the rest of the total 40 clinics, so we had a live control that was close enough in many respects. But I think that this is not the job of this project, but for a long time within IOM, I've been lobbying for more work on producing rapid cycle techniques or methodologies that would be validated for delivery systems using resources they can afford to do, because we really need to get more reliable evaluations. And interestingly, lots of the for-profit systems themselves may not tell you all of their secret sauce, but they have to report evaluations to their customers, whoever they are, and those use the same data systems essentially within the delivery systems. So you actually can get at, in collaboration with them, whether it's actually working and producing the results that you want, even if you don't have access to the engine of what's producing it. So you can at least ask that question. So I don't know, Mike, if you have any, maybe the roundtable or others are pursuing this and I'm just not aware of it, but I just think there's a huge need for the rapid cycle evaluation methodologies.
We have a number of activities underway. I won't go into them all, but it's part of our effectiveness research agenda.
Okay, sorry.
I wonder whether, when we're looking at the models, there's a level of reform, one level deeper that we aren't particularly getting to, and that is geographic. We talk about health plans and health payers and so forth, and any one area has many, many different payers and plans. But once we start having to serve people at home, I work mainly with the elderly, there's tremendous waste in sending 2 nurses out to see 2 neighbors just because they're in different insurance systems. This one nurse ought to see both people rather than spending all that time with windshield time. And an awful lot of the services are actually geographic. Workforce development and home-delivered meals and so forth are actually geographic. So you can't fix the waiting list for housing or meals for one hospital or one health system. You have to fix it for the community. So shouldn't we be at least thinking about reform at that level, even if we can't yet see examples except in very unusual circumstances? And also just a coda in response to what Molly was saying, maybe we should also be thinking about some social impact bond kind of funding, or pay for success kind of funding to help with these startup costs.
Actually, there are some hospitals that are using the social impact fund, and we can't take time on that now, but for those interested in pursuing it, it's a very important source of funding for specifically some of these kinds of programs. So I think that's a very good idea. There also are some very important models of community-based community social services and behavioral health and other service support systems that are built to contract with multiple health plans and provider systems in a single area. This is going on in New York City. It's going on in Los Angeles, in several, I think in Seattle has one as well. So I think it's something to be encouraged because there really is there's a business model for them that could work.
Just do the medical care also. Not just the social services.
Well, I think actually this is more important than the medical care but in terms of producing these results.
The VA and the Indian Health Service have developed a trade-off where they can see each other's patients.
Right.
You know, why can't United and Aetna?
I agree with you about the local stuff. Joanne, the Robert Wood Johnson Foundation has their Culture of Health initiative that is trying to do that more community-based kind of all-in effort to see whether they can improve health at the local levels. Hopefully there's some movement anyway there.
So, Joanne, I think you raised 2 points. One was on geographic delivery models. I think the first step for us is really around payer alignment, which you could think of as phase one before we can get to real geographic delivery models, which is a great idea, but perhaps the future. On payer alignment, we are using a couple of different strategies. One is in CPCI, we actually convene payers in 7 different markets around the country. So the applications were in 2 phases. There was a payer application first. Based on the payer interest, we chose regions and then solicited provider interest. The other strategy is in many of our models, we ask the providers to go out and bring the other payers to the table. So in the Pioneer model, we require the pioneers to have more than 50% of their book of business in risk-based contracts by the end of year 2. And for the most part, they've easily achieved those goals. The second question was really interesting around social impact bonds. I agree, and it is something that we are exploring. I would add that if you look at the financial architecture of, say, Comprehensive Primary Care Initiative or any model that includes a care management fee plus an opportunity for shared savings, it has many of the features of a social impact bond. It's not exactly the same in terms of the funding flows, but CMS is paying an upfront fee, so we're funding the upfront infrastructure. We are taking the risk, so it's one-sided risk for the providers. And if there is a reduction in total cost of care, both the providers and CMS see savings. So it has some of the similar incentives of a social impact bond.
Simon?
Just wanted to come back to a question about taxonomy that was raised. I'm hearing a little bit of a dichotomy between approaches of using, I guess, more traditional ICD-9 based chronic conditions to identify and stratify patients versus age-based broad combinations and more functional. What are your thoughts on this?
Well, I think maybe all of the panel will have some comments. I think the functional is frankly much more useful in practice. That's why I said, even though I can relate for policy or reimbursement or large population allocation of resources to a more refined segmentation, when you're working with a population of 200,000 or less, you basically are at the point where, yeah, we're going to essentially do our intake of people with several chronic diseases this way as adults. We're going to do our advanced pediatric home this way. And then you customize it for the individual patient or the diagnosis as you get them in. But it's much more practical approach. And what Craig laid out was really beautiful in terms of our experience of trying to build that kind of program, is that within any level of need, you've probably got another, if you remember, he had 2 or 3 subsegments in each level of need. And those were critical differences in terms of the resources you needed to bring to bear. So I think that he's right about that, and he's right about the workforce characterization for the future as well. And certainly, that's the way most delivery systems are actually operating. When they are doing their financial modeling, they may use a much more discrete, semi-clinical kind of diagnostic cut on it, but it really starts as that level of care approach.
I think it varies a lot with who the payer is. I mean, if you're Medicaid and you have to pay for long-term care services, then you have different segments that matter a lot for what you're going to do. We have different costs and different needs you have to deal with. And behavioral health is a critical issue that cuts across however you define things on ICD-9 codes. Housing is, as Joanne mentioned, is a huge issue too. There's on the Money Follows the Person program that we're evaluating, there could be a lot more transitions out of nursing homes and back into the community if there was adequate housing.
Frederick, and David, here in the last presentation, comment on this.
Great. So just wanted to mention on social impact bonds, we wrote a paper maybe about a year ago on this from the perspective of governors, and I think we're very nervous about them. I think there's a great theory there, but in practice, what we've seen has not been particularly great. So if anybody's interested, we can circulate that to the group, and they can get those thoughts. I wanted to make one comment and then one question. The comment is this. I think some of the stories, first of all, thanks to the panel, terrific presentations. Some of the stories that we saw were not stories about superutilizers. They were about sort of traditional efforts of health systems or physician groups to drive towards efficiency, right? And then some of the stories we saw were about superutilizers or about high-need patients. And so I think we have to be careful. For example, with CPCI, I think in some ways that is the story of taking a lot of resources to a broad population and not targeting the way that we've all been talking about with superutilizers. So I think there's a lot of interesting things going on there, but the discussion around high needs patients is about figuring out how to segment populations and then target resources. So we've sort of got a few different, I think, stories going on in this presentation. The question I have for the folks is we are struggling from a governor's perspective, from a state perspective, of how do we incentivize and build the policy framework in states to allow these high needs patient interventions to flourish. And one of the things that we run across, and Jeff Brenner I think is very eloquent on this, is in addition to readiness assessments for patients to see whether or not they're actually movable, Jeff also his team does readiness assessments towards the provider community to figure out whether or not the actual practices can move. And I'm just wondering if the panel had any comments about that, about the experience of actually trying to get the culture, the provider culture, to move into the needs of the high-cost patients.
I think you should add a third thing to that, and I was health commissioner in New Jersey and health director in California, and I think the NGA has a big task in front of it. But I think that you also should be looking at the ability of the delivery system, or if you're to remove the plan, to actually extract the savings and deliver them as reduced premiums. Because ultimately, we're not helping the family and the patient who pay a lot of out-of-pocket costs. We're not helping the state budget. We're not helping the community sustainability if we don't actually lower total costs to the payers. And unfortunately, you really have to divide. If you look at all of the elements of care that we're proposing, some of them are actually pretty likely to be able to deliver savings. If you don't have someone go to an ED, in theory, under any PPO thing, you're going to save because you're not paying for the ED visit. And if it's a true managed care and you've managed to, despite with PBGH's help, track that, you ought to be able to try and extract the savings. But if you're doing labor substitution, a lot of this is using social workers or a community health worker instead of a physician or a nurse. Very few health systems are ever going to fire a nurse or cut their number of docs on staff. And so you may improve the efficiency of care and never realize the savings. So I think that, along with the initial high investment that's required, and what I call the myth of gain sharing, are all really important issues in trying to get what you want accomplished.
Yeah, certainly shared savings is a potential, although I think like the CPC practices have expressed some reservations about the likelihood that's going to materialize for them. But I think what you really need is evidence. If Jeff Brenner's programs are great, and if he can do a decent evaluation of that and show that this is what the savings are, this is what the state can pay, and still generate some savings for the state and make it worthwhile for the provider, then I think the people like Jeff Brenner will come and adapt his model, and the state should be willing to pay for it then. The same, and Bob Master has been making this kind of argument for many years with Commonwealth Care Alliance, but the payment has to match the needs of the population, and sometimes it requires a more refined risk adjuster than what is being used.
So I actually just want to make sure that I understand your question. What I took from your question was something around the level of provider engagement and the correlation between provider engagement and culture change and performance within models. Is that about right?
Yeah, more or less just the notion that I think there's an assumption that if you identify these high need patients, you identify their needs, and the providers can just sort of adjust to meet those needs. But I think one of the things that at least Jeff has talked pretty articulately about is that, in fact, there's lots of providers, practices that just don't have that capability or that interest, and that you have to make sure that if you are, for example, provide capital investment or ways to support the transformation, you found a practice that's ready to actually transform.
Yeah,
and I'm just wondering if you guys had run across that in your.
I mean, that's a great question. So we look at provider engagement in a number of different ways across our models. It's part of the evaluation of a number of our models, both before entering models, during, and after. And there are a number of ways of getting at it. So there's a cultural aspect to it. There's also a financial aspect. So in something like CPCI, the vast majority of practices are small. They face the financial incentives, between CMS and the provider directly. The ACOs tend to be larger, and so there we actually track how the ACOs are paying shared savings to providers. So whether the docs are salaried, whether they are essentially fee-for-service and receiving a cut of shared savings, or they're at risk for losses. So there's a financial piece to this. But there's also a sort of a cultural engagement piece. And there, my strong hypothesis is that there is a high correlation between engagement and performance in a risk-based model. The strongest evidence for that, I think, is probably not from our work, but I know in the Care First medical home model, they see a strong correlation between provider engagement and performance within the PCMH construct.
Okay, let's batch them here, David and Peter, and then we'll hear from Diane and Steve. So take these two in sets of two. So David and Peter. Oh, sorry.
All right, thanks. So actually, Frederick mentioned that he thought maybe CPC didn't have a segmentation. It was sort of more broad. I actually sort of took a different approach, is that there were different kinds of segmentation that were going on in these different examples given. In CPC, CMS gives a kind of segmentation by setting a rate across different risked populations. And I wonder if, based on that experience and that granularity of the different kinds of segmentation you did, and the fact that you allowed different groups to do the segmentation, in CPC, again, the providers did some kind of segmentation, and they also did some kind of targeting in many of these. Tell us a little bit about your experience. What do you see that might need to be done different in terms of the segmented populations? And how do you think that translated to the other kinds of segmentation and targeting? Because that was a big issue for us. Like, what's the purpose of segmentation unless you're actually going to offer these different models?
Yeah. Okay. Excuse me. Thank you. So my comments were about independence at home, as you can imagine. I wanted to reinforce one thing that was said at the podium, which is the importance of a learning collaborative, which we created by virtue of a grant and are now extended in the 2-year legislative extension by tithing that all of the practices have agreed to participate in because we recognize the value of putting our heads together as the VA has done with home-based primary care. Second comment in response to the upfront cost aspect of this and the opportunity to participate in some sort of advanced funding. I was in this building on September 30th in the afternoon of 2009 when the Baucus bill was going to mark up that night, and we were on the phone with representatives of the congressional leaders who were putting independence at home on the agenda, who were in turn in contact, I think, with let me think who was I know CMS was party to the party and somebody else. In any case, we were told that layered payments or upfront payments would be a deal breaker and we'd be on the cutting room floor with respect to the proposed shared savings demonstration model. And so I respect the need for fiscal integrity, I think, in any kind of payment model, whether it be in partnership with CMS or with another payer. But there is still a significant upfront cost. And so one of the things I hope will come out of our collective deliberations is an understanding of the way to use aggregated data acquired to this point and understanding of risk adjustment and predicting cost models to allow us to fund these shared savings demonstration programs or other types of initiatives of that sort more quickly, because we did experience quite a bit of heat in our local environments related to the hope for shared savings payments as we had invested, and the CEOs were looking over our shoulders pretty intensively. And those are the things I wanted to mention with respect to independence at home as an example of, I think, a successful model.
Okay, if I can remember David's question. One of it, I think you were asking about practices. How do we get them to provide them some information on how to deal with further segment their populations and deal with them more effectively? Is that the?
Yeah, and like what, based on the experience, might be done differently to better segment in preparation for that?
Yeah, I'm not sure that you want to tell practices how to segment their own patients. I think, they know the patients really well. I think the current system is, here's the payment mechanism, and we pay more for the people in the top quarter, and then you figure out how you want to triage those patients that are in that high risk or even not in that grip. They're not bound by that. So it's more flexible. So are there any lessons overall? Not sure about segmenting. And one of the things that we're doing at the moment, though, is taking the 500 practices as 500 observations, and we've got these measures of changes that they've made in how they segment their patients and how they both risk stratify and do care coordination, and trying to link those changes that we see over time, baseline levels and changes, to what happens to their hospitalization rate for their patient, for their attributed patients. So hopefully we can start linking these changes that are trying to be, that the program, the CPC program, is designed to initiate in the way practices behave, to these are the ones that produce the best outcomes. So for any given practice, the practice is usually too small to have a whole lot of confidence for that particular practice. But on average, that's just a random error. On average, we should learn some lessons, and we have been so far. So that'll hopefully be out in the next month or so. Our first look at that. There's a lot more to be done with that.
Okay, we're actually going to wrap here. It's 2:35. So thank you very much to this panel, and we'll have more time to keep the conversation going. Thank you.